Hi, I'm Corinne Young. I'm your host today. I'm a nurse practitioner and the current president and founder of APAP, the Association of Pulmonary Advanced Practice Providers. And today joining me is Brian Bizik. He is a division assistant with over 20 years of clinical experience. Currently, he is the respiratory and allergy care coordinator for the Terry Riley Health Centers in Boise and Napa, Idaho. Brian is also the past president of the Association of Physician Assistants in Allergy, Asthma, and Immunology. He teaches for both the Idaho State University Physician Assistant and Nurse Practitioner programs in Boise. And if you've been listening to our podcast, you probably recognize Brian. We've had him on a few times. COPD and asthma is kind of his jam. And last year, he brought us the 2025 Gold updates. And this year, he's bringing us the Gold COPD 2026 updates. So, Brian, I'm going to hand it over to you.
Thank you. Yeah, like the seasons and Christmas, it comes so quick every year. The updates come fast, and I can't believe it's Christmas, but they tend to come about the same time every year in November, so that's great. Glad to be here, and it's fun for me to get to share this with you because we have very good guidelines. Both GINA Asthma and the Gold COPD guidelines are so helpful. They're updated annually, which gives us a running commentary on where we are with the data with COPD. So that's what we're going to do. And I do have some slides. Well, I'll show those. If you're listening on the podcast, I'll kind of describe those. So hopefully it makes sense to you while you're driving to work or working out. And this hopefully will get you caught up with where we are. What changes have there been in COPD care that make a difference to us that really will affect what we do in the clinic. So these are updated annually. The Gold Committee meets twice a year in person. They finalize the report at the end of every year. They meet in ARS and then they meet at ATS, and those two meetings kind of put together the guidelines, and then they put them out at the end of every year. And when this is released in November, it's a very good scientific update of what we've learned in the past year with COPD. And they also made one of their goals this year that they made very clear is they try to make the document more readable. It's still pretty long, but I will say it's very readable. So if you need to check up on something in the guideline, I think you'll find pretty helpful. So I'm going to highlight the changes for 26. A couple of reminders from last year, not very many, because I really want to focus on what changed. So if you're familiar with what we've been doing in 24 and 25, this will help just say, okay, what's new this time? And I'm going to present the changes in the order that they were done at the Gold meeting in Philadelphia. So it's not quite in the same order as in the guideline, but I think it'll make sense when the order that I'm doing in. And I really want to focus on the why. So the why are these changes important? Like, what do they make a difference to me and you in the clinic tomorrow? How do I make it, is this going to impact? And so what changes do I need to make, or how do I need to rethink, or how do I talk to my patients about COPD? There are some very important changes in kind of the thinking of COPD and trying to refocus us. And those changes are then, you can see how they'd come out in the recommendations and the guideline themselves. I am showing one quick slide on the EDO types, that's not a term you're familiar with. This is Gold wants this to be used. And so you may see it. And all it is adding a letter after COPD. So COPD-G is for those patients with COPD from a genetic cause. So you may see that in the literature. And it just was re-emphasized, even though the EDO types was listed last year. They updated and just kind of want it to be, make sure that we're using those. The big change is this idea of disease activity. So Gold has made a big effort to add some new nomenclature to us, but change how we perceive and how we think about COPD. And the phrase that was used over and over again is this chronic inflammatory disease. Think of COPD like you would think of rheumatoid arthritis or a diabetes or some kind of chronic inflammatory disease. COPD is not a series of events. Just like asthma, I think the biggest problem we have in asthma, or one of the biggest, is that we treat asthma as a series of acute events, and it's not, right? It's every day. And when we just treat the acute events, we're not doing the patient any favors. Same thing with COPD. So Gold says, look, at this year, 2026, we're going to have this idea of a chronic inflammatory disease. Two terms to kind of help us quantify that. One is disease stability, and one is disease control. So that's the buzzword, but the meaning behind it is clear. We need to address COPD as the chronic inflammatory disease that it is. It's 365 days a year, and we need to address it that way. When it comes to disease stability, this means no worsening of symptoms, no exacerbation, and highlight, no increased loss of lung function. Now, we've been talking about exacerbations the last few years and trying to stress that these are very detrimental to the patient, that a severe exacerbation in COPD, the closest thing that you can compare it to is an MI. And we weren't thinking that way before a few years ago, but we are now. This just takes it a step further. When you have disease stability, you feel good, you're not having the exacerbations, and the loss of lung function is not accelerated. That's the goal. And so when you talk to patients, think about, you have Mrs. Jones sitting across you. Mrs. Jones, you have COPD. I really want to make, let's say they're there for an exacerbation. Mrs. Jones, we're going to take some steps today to get you better. But I really want to talk about how to keep you better. I want to keep your disease stable. And the other term is control. I want to keep your disease controlled, because that means that you're doing well and you're not having rapid loss of lung function that we know happen when the stability isn't there. Control, the way the wording from GOLD is, it's the same thing as stability. It just adds in this idea of patient experience. Their level of disability is at some threshold that we don't want it to go up. If they want to play pickleball, we want them to be able to play pickleball. We want them to do the things they want to do. So talking about COPD, hey, we want to keep it stable and controlled, like the volume on a radio, we want to keep it down, all right? And the guidelines are really reflecting that. There's a couple of slides that you'll see if you look at the updates from GOLD that just talk about how to do this and what our real goal is. And it's minimal symptoms, they're doing well, activity is low, it's stable, and they're doing what they want to do. And that's our goal day in and day out. Because of this, so think about this. We're addressing this as a chronic inflammatory disease. We want to keep it stable. We want to keep the inflammation down every day, okay? So to do that, we're going to rethink a little bit the treatment guideline. And the main change is just being more aggressive when patients have just one exacerbation. So if you're familiar with the ABE, on the side of the ABE treatment algorithm, it said last year and the year before, it said, one exacerbation or two or more. And now it's different. Just drop that down by one. So it's 0 exacerbations or 1 or more. Why? Because we're trying to get the disease stable. And the big one with this is, if a patient has even a single exacerbation, moderate or severe, doesn't matter. If they have one, they're likely to have another. So Mrs. Jones, you had an exacerbation. That means your disease hasn't been stable. We've got an uptick of this inflammation. And you know what? It's the risk of having another one this year is really high. And even though it wasn't maybe a severe exacerbation, that's the risk. So I need to intervene now. We need to address this now, not wait for another exacerbation and say, okay, this is your second one. And so this is the big change. The other one is GOLD does a very good job. And I really like this. And that is separating patients out to initial or ongoing therapy. And kind of addressing patients differently based on whether this is the first time you're putting them on a controller or they've been on a controller and now we're adjusting therapy. A couple of slides I'm going to show, and if you have a chance, you can certainly look at it's a free download off the GOLD site, but they are showing, GOLD is giving us this algorithm that just says, okay, if they're initial treatment, we're going to have one diagram, and if it's ongoing and you're just adjusting, we have a separate diagram. The initial treatment one is diagram 3.8 and then 3.9. So I'm just going to review those and talk about what that means. The first one is the ABE criteria. And if you're seeing the slide, you can see that the treatment is still the same. I'm going to give them medicine for COPD based on how have they been and how are they doing. So how have they been? What's your exacerbation history? And how are you? What is the the Modified Research Council guideline, which is that one question test, or you're using the CAT test? So how have you been? Exacerbations. How are you doing? What are your symptoms? Those two parameters help me decide what medication to give. The change is that first group has 0 exacerbations. So the first line, if you can kind of visualize it, the A and B group is 0 exacerbations, with A being those with minimal symptoms. So their MMRC is 1 or below, which is most of our patients that see us for COPD aren't in this level, right? This would be a pretty stable patient, or those with a little bit higher. So 2 or more on the MMRC, or with the CAT, it's greater than 10. So no exacerbation, symptoms very low. That's the only group that GOLD says that's the group that can be on a single bronchodilator, not 2, just 1. That's not going to be most of our, that's going to be, I don't know what number, there's no numbers, but I would guess that's 5% of our patients. That's not very many that really have very few symptoms and have 0 exacerbations. If their symptoms are high, but they still have had 0, then that's group B, and that's a LAMA-LABA combination. When you're going up to the top rung on that guideline, if you can kind of see it, that's 1 or more exacerbations. And that group gets the LAMA-LABA and triple therapy if indicated, which I'll get to in a second. So that's the big change with the AB, is just looking at the exacerbations differently. The diagram for ongoing, so if patients have already been on therapy for a while, there's no big change to that one at the top part. And so if you're seeing the slides, I'm highlighting it. We have LAMA-LABA, that's our therapy. Initially, we're going to move them to a LAMA-LABA combination right away if they're struggling, right? So this is patients that are already on therapy, but I'm going to step up. If those patients have eosinophils over 300, I'm going to move them to a triple inhaler. We know moving to a triple inhaler is the right thing to do for these patients. Do it early, don't wait. Waiting doesn't do any good. There's lots of data to support that. So we want to do that and move them to a triple. If they're already on therapy, but I need to step up, and their eosinophils are below 300, then I'm going to make sure they're on a LAMA-LABA combination. So I'm going from a single agent to double, and I'm treating them that way. Now, if that patient comes back, now they were on a LAMA-LABA, their eosinophils are below 300, and I did not put them on a triple, but now they're back again. Maybe it's 3 months later or 6 months later, and they're having a flare, or their symptoms are out of control, or they're not having good disease stability. They're not able to play pickleball, whatever, and I'm going to step them up. Gold says, okay, you can kind of readjust your therapy. And now giving them a triple inhaler is okay if their eosinophils are above 100. So it changes from 300 to 100 that second time around. That is very similar to where we were in the past. The change comes just below that. Now, the guideline that they give us, there was a stoplight, and it was green, yellow, red for who to give steroids to. The only change with that is, and this was a big kind of a funny deal, but yellow, it used to be yellow in the middle, and now it's green. It's light green. So it goes from dark green to light green because people said yellow means stop, and we need to learn to stop at the yellow lights. So they got rid of the yellow. But otherwise, the who gets steroid graph really didn't change much. When we want to go on, and this is kind of where things are changing rapidly, is where do I go past this? So you have a patient, they're on the appropriate, you've maxed out their inhaler therapy. Again, this is a patient that you've seen a couple of times. They're coming back. Now, because I'm seeing them a couple of times, the eosinophil cutoff is 100, not 300. So now I'm putting them on a triple therapy unless they can't be on that for some reason, or their eosinophils are below 100. But now I want to advance. So this is where I'm going next level, if you will, adding in more therapy past inhaler. And so what I put, and this is just kind of my interpretation, is for primary care internal medicine, if this is you and that's your practice, once you've maximized inhaler therapy, you just got to know that there's a whole nother level. It's like another floor to a building. We have a whole new suite, I don't know whatever word, I'm using real estate terms, I don't know, a whole suite of options available to us. So if you're in internal medicine or family practice and you're doing this, treat those patients, move up to the next level. Gold does a good job of showing us which options we have based on their primary symptoms. If you're not comfortable, that's okay. That's the time to get them to somebody that will, because it's another level of therapy and we need to move them there. If you're in pulmonary care, this is a time to be aggressive and say, again, Mrs. Jones, we're moving up to this next kind of rung, if you will, with these options because your disease control isn't there. You have a chronic inflammatory disease and it's not under control. And we're seeing it because you're not playing pickleball. You're having these flare-ups and we're losing lung function. So now I need to move your head. So if you're in pulmonary care, just know that this next level is there. And on the guideline, it highlights if persistent dyspnea is kind of the main complaint. We have ensifentrine, which is a very good PDE3/4 inhibitor, and it's just a very nice add-on therapy. Then on the side where Gold says if having exacerbations is a big problem, we have roflumilast, which has been there for a couple of years. We have macrolide therapy, in this case with azithromycin, and then we have 2 now biologics. We have dupilumab and mepolizumab, so 2 different biologics that are indicated for COPD for patients who have, more of their inflammation is coming from that type 2 side. So if that's the case, we've got 2 biologics. So the main take-home point that Gold is saying is step them up, get them on the right therapy, and then if you maximize the inhaler side of things, know that there's another area that you can expose them to, and there's good options for most patients. And this is where we get into just controlling the inflammation and keeping inflammation down and keeping the disease at bay. which is the main focus of this 2026 update. There is a nice slide that Gold put out this year that's new that just compares the data from dupilumab and mepolizumab, and they're not head to head, so that you can't compare that way. But this does a nice summary showing what effect did this have on exacerbation reduction, and also quality of life. The St. George questionnaire was used to kind of see quality of life, and one of the 5 trials listed did need significance on that. So I'm going to pause there. I don't know, Corinne, if there any, so that's just kind of the main therapy changes with, Gold and focusing on disease control and moving ahead if needed. Any thoughts on where we are so far?
So the change in exacerbation threshold I thought was very key because those of us that have been in the game for a while, 2 has always been our cutoff. And we even have these old-fashioned rules of 2 for asthma. I don't know if you remember those, 2 exacerbations in a year, or 2 rescue inhaler uses in a week, or 2 nocturnal symptoms in a month. We've always kind of held this rule of 2 as being too much. And we translated that over to COPD. 2 exacerbations, outpatient exacerbations were too many in 12 months. And now our goal is 0, which I think is great because it really brings home the dangers of exacerbations in these patients. We lose lung function, which increases the frequency of exacerbations and reduces their abilities. And then this is what eventually leads to their demise, in so many of our patients. And we know now there's a lot of cardiovascular impact the more exacerbations they have as well. So I'm glad that's a new point. I'm hoping it reaches, primary care and everybody else, because you and I both know a lot of times we see these COPD patients and they're having 6 or 8 a year before they ever see us.
Yeah, and they think, and that's considered kind of quote unquote normal, and it's not okay. And when you look, the data presented at the Gold meeting was, as soon as they have one, you can look and see that they immediately go into this other category of just high likelihood of having disease instability and more exacerbations. And going to 2 didn't really change that. If you have 1, you're in this other category, and if you have 0, and so that's the change. So lots of logic and reasoning behind it. It means maybe a little more work for us sometimes, but it also changes the conversation we have with patients. The next section, the next big overhaul of 2026 was exacerbations, and this chapter was completely revised. And the main change was that previous to this guideline, what we did to kind of evaluate an exacerbation was what happened after the exacerbation, or what therapy was used, or whether they were admitted. And so this is this after exacerbation impact, and not really what was happening during it. And so if you can see the slides, I copied and pasted this. I'll read this to you because I think it's so interesting. Just how Gold phrased it in the guidelines, and it says, and I'll quote them: over the last 2 decades, the severity of an exacerbation has been classified post hoc, primarily based on healthcare utilization and the treatment implemented. Then I love this. This is probably adequate for clinical trials, but useless at the point of care. And so I love that. I like, hey, this is what I've been doing, and if you're in the clinic, it was pretty much useless. And it wasn't helpful to know what % of patients ended up in the ICU. Good stuff, but just not changing what I do. So Gold says, look, we're going to rethink this. And so we're going to use the Rome criteria, which help us, judge the severity of the exacerbation, thus what I need to do, what treatments and where the patient's going to go. They do have a new kind of a slide that goes over kind of how I'm going to assess that. And then there's a flow chart. The patient comes in, they've got COPD, and they have an exacerbation. What criteria am I going to use to assess this? Now, there's been, like hospital protocols have been using something very similar for a long time. I know CHOP, the Children's Hospital of Philadelphia, they use something very similar to this for a long time. But this is the first time Gold has implemented. And for those of you who can see my slides, I just took the middle section and blew it up. And the key for those of us that are in outpatient care, if you're in urgent care, if you're in the ER, and you just not, am I going to treat this exacerbation here and send this patient home or not? And that's the line in the sand. Do I need to keep them? Do I need to maybe sit on them in the ER for a few hours, or do I need to send them to the floor, the unit? And the guidelines are very clear. And Gold says, look, you can look at their scale kind of just on a 1 to 10 of how severe they are. Look at their respiratory rate, look at their heart rate and their stats. The respiratory rate When that gets to, in my head, I've always used 25. They see 24 breaths a minute or more. Their heart rates, I use 100. That's easy to remember, but they say 95. So heart rate above 95, respiratory rate above 24, or SATs below 92. That patient goes to the moderate or more, right? It could be worse, but at least the moderate category. And those patients then are going to be, you're going to send them somewhere. And that makes sense. So somebody comes in, they're having exacerbation, they're breathing 30 times a minute, their heart rate is over 100, their SATs are below 92. I mean, that's just not somebody we're going to send home most of the time. So GOLD really does a good job of saying, let's use these criteria. The Rome criteria are the basis. That was a guideline in 2022. It came out of Rome, Italy. That's why it got that name. And just helps us really try to understand how to grade these and not just post hoc data, but what's going on at the time. So very good guidance, very clear, very specific, very readable like they wanted it to be. And then the guideline goes through all of the treatments. And my preference would be at some point we have a talk just on exacerbations. And because it's one where wherever you go, you can get vastly different therapies. So GOLD does a great job. Okay, who gets steroids and why and what does it do? Who gets antibiotics and why and what does it do? And what, how do I treat these patients? And then do I need to keep them? Is it okay to send them home outpatient therapy, or do we need to do something more? And now we have a litmus test that we can use, an evidence-based, to make the decision about what we do. And then what the slide I'm showing is just what are the key points of the management and when to give, when antibiotics are appropriate, they're very effective. So how do I determine if they're appropriate? The guidelines, 2026 guidelines, really delve into that and do a really good job. And who gets, systemic steroids. And I do like that even on the summary, they say duration of therapy, 5 days. So I still see those 10-day, 15-day patients. And sometimes that's needed, but most of the time, no. All right. And then so that is kind of how to treat it. And then the last thing GOLD says on this is they have a whole new section, just what else do I need to consider? So we get on a track and it's a COPD flare and we just kind of leave it there, but really stressing, considering, pulmonary embolism, considering in MI, heart failure, all of these things, they have such a big part of the exacerbation. Okay. Switch gears just a little bit. So the exacerbation chapter completely rewritten. Then I'm going to just kind of highlight these very quickly, just a minute on or less on each one of these. But there's kind of a couple of other areas that changed in the guidelines this year. First one is case finding, just meaning we can't just wait for patients to come to us. We have to go look for them. Another one on vaccine changes. One statement on alpha-1, which I have to put in there because Corinne and I, we couldn't do our job if we didn't talk about alpha-1. Multimorbidity and COPD, and we need to be assessing that. And then just a note on technology and AI. So these are the big ones. First one was case finding. And the take-home point is that GOLD is saying we're still missing a lot of patients with COPD. And we can't, if we're going to do a good job and we really are going to impact, we got to get those patients. We need to know, we need a diagnosis. We need to at least help them understand where they're at. And the one thing I highlighted, and this is, Corinne, for you and I mean, this is a mandate, and they say it as such. And GOLD is saying providers have a poor understanding of COPD and the diagnosis. And Lord knows that is so true. Inadequate training and inadequate investigations and referrals to specialists. They are calling us, APAP and other groups, to help fix this through training. So one of the ways we can help is get our colleagues trained on what this is, how to diagnose it, feel comfortable ordering spirometry. And so lots of ways that GOLD talks about finding patients, but one of them is to make sure we know the criteria, and our colleagues in family practice and internal medicine who treat a lot of COPD are screening those patients. Maybe they just have a cough. Well, is it COPD? And getting them to ask those questions. And then there's an algorithm that for case finding, and it's very good, but it just doesn't necessarily change what we do in the clinic day to day, but very helpful. And I did put a plug in. If you're curious about a little bit more about case finding, there's a video on the COPD Foundation website. Dr. Jean Wright puts it up, and it's called COPD Begins in Childhood, and it's for clinicians. If you haven't watched it, I just plugged for it because she's amazing, and the job the COPD Foundation does is so good. So if you want a little more information, that's a very good video. Next section was vaccines. That section kind of got updated. I did post here the new guidelines. There's just a couple of changes with those. But when it comes to the specific guidelines or what to give, that didn't change much. But the emphasis did. So 2026, gold change is to change the emphasis of vaccinations with COPD. And the emphasis is on using this as prevention for future problems. And I just shared, this is one of the slides. This is not in the COPD set. This is one that was shared at the meeting. And this was from a cardiovascular group. And the take-home point was this: when patients who have heart disease are given vaccines early and get them the appropriate ones, the outcome in prevention of really poor outcomes and cardiovascular events, that rate reduction was similar to not smoking, similar to statin use. So we don't think of it that way, but thinking of vaccines as powerful as a therapy and as powerful as smoking cessation for some of our patients. And they share data like the RSV data is very, very good. The other data is not quite as good. But so they've just changed the emphasis of vaccines. So I wanted to point that out. In the guidelines this year, the recommendation in a sense didn't change, but they did put in a sentence, and this is no small feat. Those of us that have been working in Alpha-1 for a while, Gold has kind of tiptoed around the recommendation. And this year they have said, and I'll read this sentence, and this is a quote from the report, page 48. It's there, I swear, I read it. Gold recommends that all patients with a diagnosis of COPD should be tested for Alpha-1 antitrypsin. So thank you, Gold, for saying that. In the past, they've kind of said, well, WHO wants us to do this, and they've hemmed and hawed, but this is a unqualified statement. Yes, you should test. So good. And we need to. We should be doing that. But now it's nice to have Gold kind of, supporting us without any qualifications or other, holdbacks or using somebody else's guideline. Multimorbidity is another change. There's a whole new chapter on this, and it was completely revised. And comorbid conditions with COPD. Now, here's the change. Here's the big change, and I don't know how I feel about this. I'm still trying to decide. This year, in 2026, Gold put out a slide that talks about the comorbidities. Okay, that's great. That's not anything new to us. They put them in clusters: the heart disease, cardiovascular cluster, the metabolic disease, the mental cluster, and said, look, these all are comorbid conditions that affect your patients with COPD. Okay, yeah, I'm great. I got that. Thank you. But then they said, here's what you need to do about it. And so when you're doing an intake with a patient, there's now a list of recommended things you ought to do, including things like a PHQ-2, which we do, if that's not maybe so bad, but making sure you get blood tests, making sure maybe you're doing a stop bang assessment for sleeplessness, making sure you're doing EKG every time. So some of these things we're doing, but DEXA scan, I don't know. I haven't to date so far done a DEXA scan as part of my intake for patients with COPD. But Gold is saying all of these things affect our patients, and you should. And when I thought about this more, I'm like, I get that makes sense. And, if you did have a DEXA scan, you might change how you, prescribe prednisone and things. So it makes sense. And then, so Gold gives that, and then they give a follow-up, and they say every 3 to 5 years, we need to recheck these things to make sure that our patients with COPD, we're assessing their comorbid conditions. Big change. We're kind of, again, kind of a mandate to us to be investigating the other stuff, right? The other things that are on the periphery, but they really affect COPD. New chapter on AI and emerging technology. And so Gold says, kind of address this for the first time. And the main thing is there's a nice list of how AI can be used in COPD management. And I won't go through those, but there's a list, and there's 12 of those kind of different ways. And then they talk about how to mitigate the problems. And I don't know how many of these problems are really happening yet, but how do we mitigate? If AI is involved, how do we make sure it's appropriate and we're doing it right? And so there's 2 slides on that, and that chapter has changed. So that's kind of the main changes in the Gold guidelines. The big stuff was changing the disease stability part and really thinking of it chronic inflammatory disease, taking steps to keep that down every day, rapidly moving them to a triple inhaler if indicated. But once you've maximized the inhaler therapy, say, okay, there's a whole nother level, including 2 biologics that are great for patients with COPD and type 2 inflammation. We have ensifentrine, brand name Ohtuvayre, which is a nice add-on therapy for patients, especially those with lots of dyspnea. And we have and roflumilast. We have all these therapies that are sometimes difficult to get because they require prior authorizations and like an infrastructure within your clinic to get them. But if you can, I think you'll find that investment in going to the next level of care, regardless of which way you go, can be super helpful and impact patients. And then exacerbations were the other big one that changed, and that can change what we do in the clinic tomorrow. It just gives us a nice way to really quantify exacerbations for the first time, and that's validated and consistent and can help us make good decisions where patients go and how do I treat them. That's the summary of the changes this year.
All right. Well, I think that was a great summary. I think them specifically coming out with stability and control could be really helpful when you're trying to get drug therapy approved for a patient. You could say this patient is not stable or controlled. Per GOLD guidelines, recommendation is to advance therapy to X. And, sometimes your prior auth folks, if you're lucky enough to have them, then you're not the prior auth person, can submit the GOLD guidelines in addition to your documentation. I feel that's been beneficial for me sometimes to submit a guideline if they're refusing a therapy for a patient. And so I think them mentioning that, I could see that being very beneficial for documentation. And then the typings of COPD, like you said, the COPD-G for genetic or the others, we might start seeing that in different documentation. Also, it may help get patients access to therapies that they may not necessarily initially get, right?
Yeah, for sure. And I love that. I love including this when you run into a wall with prior authorizations, because you're right, they do respond. And I don't, somebody said it's AI reading them, but maybe,
Right.
okay, maybe whatever. But when you say stuff like that, like this is guideline based, to do, recommendations, and this is not where we're at. We're not at goal. Wow, that could be very powerful. Yeah, great. I didn't even think of that.
Mm-hmm. The other thing I think people may not be very well aware of, and you can speak to this, is that you can attend GOLD. You don't have to be on the committee to attend the meeting. And I know you've attended before, correct?
Yeah, and it actually, it's very good. It's very concise. It's it's a 1 day long meeting. A lot of their talks, it'll be like an hour-long talk, but they'll have 3 different components to it. And actually, there was some humor this year, which I thought was fun. There was some give and take. So a really good meeting. Now, it's not APAP, all right? It's not that level, but it's only, you can't expect GOLD to keep up with it. So, but yeah, but it's a good meeting. But yeah.
Yeah, I think those of you that are really focusing on COPD, we just did a podcast on COPD run clinics by APPs. That might be something that's likely going to pick up steam as APPs are doing more chronic disease management. This would be a great meeting for you to attend, in addition to APAP's meeting, but of course, great meeting for you to attend just to really get some great, concise data and meet the authors. I mean, that's the coolest thing, is those guys are guys and gals are very accessible to meet and discuss with. So I think that's a great meeting to go to. I am also with you, Brian, on all the comorbid testing for APPs or for anybody, providers to order. I know that I do talk to my patients if I know they've had a lot of steroids about, have you had a DEXA scan? I do recommend you discuss that with your primary, and I usually turf it, try not to order myself. But, the recommendation for us to be looking at LFTs and to be looking at DEXA scans and all of that, definitely, I agree, is a little more burden on the pulmonary practice to do. But I know you've experienced this as well. A lot of times we might be the only provider they're seeing. They may not really have a relationship with a primary care for whatever reason. And, somebody's got to pick that up. But it's definitely a load to pick up.
Yeah, you say, who's your primary care provider again? And they say, it's you. And you're like, okay, well, yeah, and it's not ideal, and I think that's a great point too. Like, and the guidelines, you talk about that, that the list that they put out this year for these comorbidities and just kind of this list that we need to be following, it does say that this is either us doing it or just confirming that these things have been addressed. And if not, then that's when we need to step up. So yeah, it's a little bit more, but, and then, more work, but those things, they're not just, they're not just superficial. The mental health side, these dramatically affect our patients, and it makes sense. It's just, sometimes it's hard, to take your medicine and know, okay, we need to do this as well.
It's been 20 years since I did primary care, so I really would have to review what is a normal bone density Z-score again. Yeah, I'm sure it's changed in 20 years, but well, I definitely want to thank GOLD for the teaching slides. I think those were great for us to be able to present. Again, if you're not able to see this presentation, you're listening to it, you can watch it on our YouTube channel. You can also watch it on Spotify. And then I also want to thank you again, Brian. Thanks again for bringing us another gold update. Appreciate the time that you put into the presentation.
Sure. Glad to do it.
All right. Don't forget to claim your CMEs for listening to this podcast, which are in the show notes or on our website under our podcasts. And we will talk to you guys on the next podcast. Thank you.